Welcome back to the Jaw Complex. We're really excited to have you back. Dr. Newaz and I are here again, and we're going to be answering some FAQs from patients. So let's begin. Dr. Newaz, one of the questions that we get from our patients, what's wrong with having a narrow palate?
Yeah, I think the way to really think about that question is, what could a narrow palate possibly be a manifestation or a sign of, right? Because a narrow palate in and of itself, sure, it can be a problem when you think about tongue space or just the very direct things that, okay, you have, of course, roof of the mouth is the floor of the nose, and you've got some pretty direct correlations there that are what we believe is obvious. But really, it's actually, a cue to look into something deeper and to see if the palate as a part of the jaw complex can be a clue to start asking some important questions about a patient's experience, history, health, breathing, posture, stability, wellness, all those things.
What does the tongue have to do with a narrow palate, and why is it bad?
Yeah, well, I mean, of course, and as I've said on a previous episode, tongue is one of the most proprioceptive organs in the body, and if you don't have enough tongue space, then that is something that can directly result in, some encroachment on the airway space, right? The tongue is living in a box. And if that box is too small, then we're going to have a consequence, right? The importance of, I guess, daytime tongue space when we're just upright and awake and conscious, and how important that is or isn't is, I guess, a separate discussion, because I think it's perhaps short-sighted to say that, okay, just increase your daytime tongue space and your sleep problems are going to go away. I don't think it's quite works like that, because the way that the jaw and the tongue behave is a complex phenomenon that has to do with what compensations is a person making when they're sleeping, when they're breathing, that may cause the jaw and the tongue, which otherwise may be in a somewhat acceptable position during upright, awake, conscious states, and that changes during sleep. Right?
How does it change when you're sleeping?
Well, I mean, it could simply fall back, right? I mean, that could be a compensation to a reduced airway and that kind of thing, right? It could be a compensation to, perhaps there are many people who breathe somewhat easily or don't perceive that they have a problem with nasal breathing during the day, but when you shut off the body's consciousness, the body is not going to perceive a very narrow nose, which one can adapt to breathe through during the day, as a very forgiving environment to breathe at night. And so you might the body is going to get that oxygen one way or the other. And so it's maybe not necessarily going to choose the nose as a primary way. So how do we compensate? We might either, the mouth and tongue might fall open or fall down and back.
So what
or we
happens when
might
the tongue...
push and grind our jaw out. This adds to the bottlenecking effect, right? An airway is only as wide as its narrowest point. And if you have, otherwise, perhaps some level of patency in the airway at the tongue base and epiglottis region, right? If the tongue falls back, and understanding how the tongue behaves when sleeping, which is, of course, the rationale for other examinations such as the DICE, right? Drug-induced sleep endoscopy procedure, where you can actually see how the tongue and how the airway tube is behaving, right, during sleep. So tongue space encroachment on the airway, we have a lot of people who may even, be airway focused or airway minded professionals who want to respect and understand the airway, who may only analyze the airway in a context of what they see in the CT scan, right? And it's important to understand that the airway is a dynamic structure, and that, tongue space or, muscle tone around the airway is a big contributory factor to sleep problems.
So when the patient sleeps and the tongue falls back, it could basically impede the airflow, resulting in something like snoring.
It sure could. Yeah. And
not all snoring is the same.
Yeah.
There's mild forms of it and extreme forms of it.
Correct.
And what are those mild forms and extreme forms?
Well, I think to kind of segue into that question, you also have we think about, of course, crowding of the teeth or crowding and constriction of the oral cavity. Of course, the tongue being one of the things that lives within that. But it's kind of what happens behind that, where you have maybe another potential kind of crowding, right? You have crowding of the soft tissues that line and house the airway, right? The tongue or the dorsum of the tongue or the base of the tongue, of which is one of them. And then you have the soft palate draping off of the hard palate. And then in a mouth that is too short, too far back, or too narrow, right? Then you could have the tongue perhaps at rest, or perhaps when falling back,
through gravity,
deflecting the soft palate up and back into the back corner of the airway, right? And so
what does that lead to? Like low oxygen? Sorry to interrupt you. Does that lead to low oxygen? And why is low oxygen bad for adults?
Well, yeah, we have more sources of bottlenecking, right? And of course, that's where, of course, as a radiologist, right, I'm often, reporting on the areas where the airway is constricted, right? That could be everywhere from, external nasal valves to inside the nose, to right behind the nose in the adenoids, to the, inferior soft palate, to the tongue base, to the tonsils, to the hypopharynx, right? And you can comment on basically all these potential bottlenecking points in the airway. And there are a lot of individuals who may not have a severe problem with any one of those, but maybe an aggregation of a lot of small problems within a few of those.
And what would that look like? Like trying to work out, difficulty breathing, excessive mouth breathing?
Yeah, I mean, if you, well, of course, and our discussion has been mostly focused on the context of sleep, but it's really also, now we're thinking about optimizing our oxygenation during the day, right? There's a certain level of oxygen saturation for which all of these constrictions we've mentioned create a roadblock, right? Create basically some kind of resistance to getting that oxygen that impedes optimization of, breathing capacity for purposes of exercise, for purposes of, what are some of
being alive.
Yeah. So, and oxygen is a precious resource that, is, our bodies are conditioned to optimize for purposes of, physical activity and, whether it's, walking, running, swimming, and, any kind of exertion, or the level at which, or the threshold at which somebody has to perhaps convert to a lesser favorable style of breathing, like mouth breathing, right? So there's some people out there that when you start to make structural improvements in the airway, that you may be able to perhaps breathe through the nose most of the time at rest, unless you're sick, congested, have allergies, those kind of things.
Can you kind of emphasize how profound that is for somebody who struggles with that on a daily basis?
We have a lot of patients that come in that have had sleep apnea tests, and some of their sleep apnea tests will tell them that they have a low AHI, and they have more of these RDIs. And I know that these acronyms are commonly used by health professionals. Can you explain what these acronyms mean, and then what the difference between a low AHI and a high RDI, how that can impact a person, and what we see amongst our patient population?
Yeah, well, and we'll spare some of the technicalities, but apnea-hypopnea index is one of the main metrics used to measure somebody's severity or presence of sleep apnea. And of course, sometimes that's seen in the medical sleep realm as a somewhat dichotomous equation. You either have sleep apnea or you don't. You either have an AHI of 5 or greater, or you don't. And if you don't, you're fine, right? And that's, of course, the outcome of some sleep studies. And patients come to us and say, hey, my doctor said I didn't have sleep apnea. Or perhaps you're trying to, educate a patient who might have a very narrow nose or deficient anatomy or whatever. And they tell you, yeah, I had a sleep study done and it said I didn't have apnea, so I'm okay, right? And usually that comes as a result of having an AHI score of less than 5, right? And then you have your respiratory disturbance.
So it's more so that's like a black and white distinction usually in the medical realm.
That's my impression. Yeah. That's my impression. Of course, then there's levels of severity assigned to those things that are well recognized in the medical realm. So they'll say mild, moderate, severe, or nothing. But when it comes to sleep apnea is thought to be, I guess a basket diagnosis for which if you don't have it, you're kind of okay. But, there are times where you can have a very low AHI, right? And you don't necessarily have apneas. You don't have episodes at night where you are perhaps going beneath a certain threshold of oxygen saturation. But you may have many disturbances to ideal oxygenation in your sleep, leading to sleep fragmentation and things of that sort, that can actually result in quality of life worse than sometimes sleep apnea. Right?
Some of the patients that we see, they may be waking up frequently throughout the night to urinate, or they'll be tossing and turning. They'll sleep for 8 to 10 hours and still wake up exhausted. That affects their quality of life in terms of depression, anxiety, being able to work, being able to maintain relationships. So this RDI, even though one may not have a official diagnosis of obstructive sleep apnea, their disturbances may impede their life and their lifestyle significantly that would go under the radar because they didn't have this classification as sleep apnea. So we see a lot of patients that are young, healthy individuals, whether they're male or female, that have these sleep disturbances that some of their medical practitioners kind of don't even give them serious thought about because they appear optically and appearance-wise look healthy and otherwise look like they're doing well, but they have extremely fragmented sleep where they can't actually go to school, or they can't maintain a job, right? And so they can't focus, or there's effect on their daily life, depression, anxiety, etc. A lot of times they have brain fog or lack of clarity in thought process, things like that. Yeah, we see a lot of patients that their lack of oxygen may be impacting stuff like depression, anxiety, low testosterone levels, and various infertility that we've heard about before. So that's something to consider.
Well, and I think, Bailey, just to kind of bounce off of a question or a point you were making earlier, that like, hey, let's say you're a relatively healthy, fit, young man or young woman who has, pretty, decent fitness. You're young, you're otherwise healthy, right? Like other markers of traditional, sort of health, indicates that somebody's otherwise healthy. So like, why are there profound issues with sleep, breathing, focus, concentration, those kind of things, right? And I think we have to also even look a bit more, a bit deeper than just the jaws, because the jaws is a huge part of it, right? That's of course a big part of things that people miss when we talk about these things, and perhaps not, mutually exclusive from that is understanding a person's neurology, right? When your central nervous system is somewhat overloaded by, this sense of structural injury in the body, right? And when the central nervous system is dealing with having to make adaptations and compensations to repetitive microstructural injuries, they may be in the jaws, they may be in the neck, they may be in the foot, then that has a profound impact on somebody's ability to heal, somebody's ability to perform at their best, somebody's ability to, perhaps perform daily tasks physically, mentally, and so forth, right? And so it's important to try to understand the origin of those problems, right? And understand that, perhaps a big part of that for a lot of individuals who are otherwise healthy is the jaws, right? It's not everything, and so it's important to, not kind of tunnel vision ourselves. But it is important to understand that in the, whole body complex, that simply assigning some level of stability to somebody's, it's a human body is a pretty miraculous structure where, you have perhaps distant effects of intervening on, a primary structure, right? Like you have a jaw problem and then you see that your knee or hip function improves. that is something that is oft reported by our patients, right? And that's pretty clear to us that, of course, like a simple example of this is that, perhaps, when let's say we have a narrower constricted upper jaw that forces the lower jaw in a somewhat strained position. Those jaw muscles recruit the neck muscles and then pull the shoulder forward, and then, of course, we're making
Downstream.
a series of downstream adaptations and compensations that will have a profound impact on our performance, if you will, right? And I'm just going to use performance as a very broad term to include a lot of things, right? And then, of course, right, as a compensation to a narrow airway or to some kind of structural injury here, right, then, basically the head may duck forward, right, because it is easier to breathe for somebody with underdeveloped jaws to kind of have the head in a forward position, rolled shoulders, right, and for every inch that the head is forward, it's like the spine becomes a fishing rod for the head, and it's like 10 pounds more for it to try to upright.
So, and we see patients that have traps issues, lower back issues, and you can see that their head posture may be that way, and then makes everything more downstream. You get more tension, you get more stress, your body's absorbing all of that. Then people get headaches and things like that.
Mm-hmm. I see a few people with lines on their neck from being in forward head posture a lot of the times, potentially while they're sleeping, trying to expand the airway, and then when they come back, you see the crease falls on. And I see that, and I'm like, that person probably has some mild form of sleep apnea, or
a lot of our patients will actually sleep kind of reclined up, right? Well, they'll put a bunch of pillows because they sleep better that way. So physically lying down is actually better for your sleep too. So if they're sleeping upright, it's preventing proper rest as well, right? And then they're doing that because one, their tongue isn't going to fall back as much, right? And then they can because they're up, they can breathe better. But now it's affecting their sleep, and now they're not getting proper rest, which affects, once again, back to what we're saying.
Right. I think this is a great opportunity to, open up about, getting somebody who's generally very unwell to an adequate state of being. And then we also have, which, perhaps is equally important for a lot of people seeking optimum wellness, from a place of general wellness and decent function to very optimum function, right? And I think it's somewhat of, I won't say it's a trend, but I would say that there seems to me to be an increased level of importance with a lot of people who are paying a lot more attention to their health. Hey, how can I really optimize my function and become almost superhuman, so to speak, right? And so tell me a little bit about, kind of what your thoughts are in that whole thing. Like, kind of more so talking about the latter. Like, what are some things that, people are perhaps missing when it comes to trying to really optimize their performance? Of course, because we know about fitness and nutrition and, that kind of thing. So what advice do you have for people who are looking to get, more out of, like push bigger numbers in the gym, get, a minute or two knocked off their mile, right? What do you say to such individuals?
So I think that's a multi-pronged approach. I think that we have to look at top down. So I'm all about this top down, right? Even when I treat my patients, like, I don't look at teeth first, right? I look at the human being, their person. So it's easy to get lost on why they're saying they're in your office, right? I'm having a headache, or I'm snoring. So I take a top-down approach. Is that person alive, right? So when you look at obstructive sleep apnea, most people are looking at the sleep component of that, right? Are they restful awake, or are they restfully sleeping? Are they tired while being awake? Things like that. The way I look at it is, there's an obstruction from the beginning of their nose, mouth, to about over here. Where is that obstruction? For the most part, where is that obstruction, right? Is that affecting their breathing? Apnea, are they getting enough oxygen into their body, right? Apnea is a lack of oxygen. Is that also affecting their sleep? So I look at it top down. So some easy signs to look at, Dr. Newaz, is, how is your jaw recessed? Is your top jaw or bottom jaw recessed, right? Do you have an underbite? Do you have narrow palate? Or, if you stick your tongue out, can you see the back of your throat? Can you see your uvula? Are your tonsils extremely enlarged? Can you do something like a mewing exercise, right? How is your tongue posture? Is your tongue, if you lift your tongue up, do you have a tongue tie? So those are some easy things that a person at home can just look at themselves in the mirror. A lot of patients may have periodontal disease that is causing increased inflammation in their body, right? And now there's a lot of research coming out that periodontal disease, the types of bacteria that's in the gingiva causing extreme periodontal health problems is actually they're finding in the brain when they're doing these autopsies that could be causing dementia, right? Or certain types of cancers. Now, a lot of people will just look at their teeth as, oh, let me just go brush for hopefully 2 minutes twice a day, but there's more to that, right? When's the last time you removed that tartar, right? That tartar and if the pockets around your teeth are open, there's bacteria entering your bloodstream, right? Now, when you look at if you have a heart attack or something like that, you put nitroglycerin underneath your tongue because it's sublingual, it goes directly in your bloodstream, right? So your mouth is extremely important to your health. Are you able to eat? Are you able to drink? So the way I look at it is a top-down approach. And then now I look at it as how do we decrease these problems, right? How do we decrease the cortisol levels from, lack of breathing or the sleep apnea, right? From being awake. Is there high inflammation in the patient? And that could be, once again, linked to their oral health, periodontal disease. Or then I look at it, okay, can we take care of the brain and the brain's impact? So are we actually breathing strategically, right? There's breathing techniques and exercises that we can use, right? You have the mewing exercises to strengthen up your muscles around your head and neck. So I think it's a top-down approach for me, right? And I don't look at it just as one thing, and you want to look at it as comprehensively as possible.
Well, and I think this is very interesting, right? You mentioned mewing exercises. You mentioned, see if your jaw is recessed and that kind of thing. How would you tell, I guess, some of the viewers how to, like, what is recessed? Like, what does, what constitutes a recessed jaw? What are some, I guess, basic eyeball tests that people can use in the mirror? And, like, of course, speaking of mewing, right? Like, we've got this mewingapp.co that, you have an app that can do some facial point analysis and other things like that kind of help, provide some spatial data points in the face to kind of assess these things. But what are some simple cues that you can say, to someone who's trying to see, are my jaws recessed?
Yeah, I think that's great. I think that's a good public service announcement, I guess. Some of the things you could see is if you're looking at the top jaw, see if it's recessed. Your bottom chin would probably come out a little bit more. You may have something like a smaller upper lip, or when you smile, you can see all the way to your molars, right? And for bottom recessed, you'd see you have like an overbite, colloquially, but actually an overjet, or your chin would be back. Maybe you look like you have a small neck type of thing. I'd say the best way to, if you look at your side profile, maybe take like a selfie and see how that looks, and then you can see how if your upper lip kind of comes forward and your bottom lip comes forward versus your side profile, and how much neck, right? Things like that. I mean, those are some type of simple.
Can you take a quick deep breath through your nose? Do you have any resistance? Like that's a test. I'd say if your nasal cavity is short, crooked teeth, could that be a sign of recessed jaw or narrow jaw? Like, are these things that they can be looking for?
Yeah, I mean, absolutely. Of course, having crooked teeth or any constriction of the mouth is, of course, a sign of somewhat underdeveloped or suboptimal architecture of the jaws. And some of those other signs to look for is, like, sometimes we can, look in the mirror. Perhaps if our mid-facial bone complex is a little flat, we might see some sclera showing, right? We might see some of the white of our eye showing, beneath the iris, right? And, for example, some other things that you can look at is the angle between, the base of the nose and the lip, right? We call that the nasolabial angle. And if a nasolabial angle is, unless the nose is very upturned, if a nasolabial angle is, say, obtuse, then you know that the upper jaw, or, right, the upper lip is kind of angling back.
So
right?
like this.
Yeah. Correct. Right. So and that can be a sign facially that you have somewhat under projected, and it's important because I think we're maybe perhaps mentioning symptoms of constriction widthwise and symptoms of progression, right? Kind of in the same category, but the projection issue I think is a bigger kind of thing that we're talking about right now. And of course, so that nasolabial angle can be a thing. And then that leads me to say that, of course, the jaws being underdeveloped or overdeveloped, of course, you have some people that are a little bit more class 3, right? Underdeveloped upper jaw, and, a lower jaw that's either edge to edge or an underbite. And then, of course, you have the overbites for the class 2, but you can have underdeveloped jaws, either jaw, in class 1, 2,
both.
or 3.
Yeah.
Right? Like you can have a class 2 where the upper jaw is too far back and the lower jaw is also way too far back.
Most dentists, general dentists particularly, will look at molar relationship to determine what could be a skeletal problem. So a dentist will say, oh, your molar relationship may be good, but both your top and your lower jaw may still be recessed.
Like the intramolar width.
No, recessed this way.
Right.
So we're looking at it in terms of where your molars are. So general dentists will usually look at the teeth and then make a class determination, 1, 2, or 3. That is not necessarily indicative of the jaw's position. So that's very, very important because somebody will have a class 1 but still have both recessed upper and lower jaws. Your bite may appear good to the general dentist, and what general dentists are looking for is the point of your first molar and how it lines up with the maxillary first molar, how it lines up with the middle of the first molar on the bottom, on the mandibular teeth, right? And so it can look like that inside the mouth, but your jaws may still be further back than they should be, which could be impacting your breathing, right? So just because it optically looks good to your dentist may still be bad orthodontically and then jaw relationship-wise.
Well, in other words, you can have a very good bite in the wrong part of the face, right? And that's something, especially in our profession, where we are essentially trying to put a bite together. Sometimes, we are, really kind of laser focused on that bite, and the end result is that we.
And I think the modern orthodontics is so focused on the teeth and the smile and the aesthetics that they're losing the bigger picture. If they have a beautiful smile but they're not sleeping and they're dying, right, in their sleep with these apnea events, I don't care how beautiful the smile looks. They got to be alive first. They got to be breathing first, right? And I think that the orthodontic community misses that. Seems to be a very logical component because we laser in so much on certain things. We definitely have an epidemic of small jaws, and I think that the research is out there that epigenetically our jaws are getting smaller. And so the problems that we're starting to see didn't happen 200 years ago, right? And so now you're seeing those wisdom teeth getting impacted, or you're seeing the crowding because the way we eat foods is they're mushier, softer, they're more processed, right? And so we're seeing those things. So the incidence of the sleep apneas are going to start increasing in even the younger generation, because of the way our jaws are developing epigenetically. Obviously, the older generation, with aging and their diet and overweightness is a contributing factor too.
Can you say there have not been enough generations for evolution to cause the small jaws as fast as we've seen them?
That seems like something you would like to say. We're gonna let B shed some light. I'm gonna sit in your chair real quick.
Can I have the mic there?
Yes, sir. All right.
Welcome to the podcast, Bailey.
All right.
Welcome. Side of the camera today. Hey, so what is your thoughts on small jaws and where we're heading as a civilization?
I really think that where we're heading as a civilization when it comes to narrow jaws is extremely detrimental to the youth and the future of our world. I saw a YouTube video by an anthropologist who said that there's not been enough generations to see the changes we've seen in our jaws over the past 200 years. Epigenetically, through our environment, there has been strict changes. For example, the baby bottle, lack of breastfeeding, lack of tough food, allergies, You can rank those among themselves, but those three things are correlated to small jaws. Why is it that in other countries where natural environmental stimuluses, such as breastfeeding, these people don't have crooked teeth? They have developed jaws. Alex Pereira, for example, a fantastic UFC fighter with a greatly developed mandible and a very forward prominent face. He was breastfed. He wasn't bottle fed. Look at the underlying denominators of these things that cause forward-grown faces. Yes, we do have an epidemic of crooked teeth, and I think it is extremely detrimental to a lot of different cognitive problems that children are experiencing. What are they linked to? These are the questions that need to be asked, and I think that extraction and retraction is detrimental and can only cause this problem to become worse. The one thing I really think about is, how is this affecting children? How is the lack of oxygen affecting the development of a child's brain?
100%.
You can't even get to the genetic potential of what they could have been 100 years ago or 200 years ago before their baby bottles were introduced.
Absolutely.
So I think that the real solution here is MSE. I am a patient myself. I did suffer with through extraction and over retraction, and I suffered with breathing problems. I suffered with focus problems. I coincidentally I was diagnosed with depression. These are things I'd never suffered with, never experienced, never even knew about until I had my wisdom teeth pulled, until I got retraction. But the fact that there are studies that show that retraction can affect the nasopharynx is extremely concerning. There's not enough research yet. But what if extraction retraction is causing airway problems? How would you feel in 5 to 10 years when you've done how many cases on children of extraction and retraction? How would you feel if you did that to your child? Not only as a parent, but as the orthodontist yourself. The standard of orthodontics needs to change. And that's why with gentlemen like these two, who are airway focused, if you want your child to be an athlete, if you want your child to be someone of importance, let's be real, they need to be performing at the utmost capacity that their brain and body can perform at. And if you're not getting enough oxygen, not only just through sleep, but throughout the day, I don't think you'll ever reach that. This is extremely serious. We do have an epidemic of small jaws.
100%.
And I think that the general consensus of orthodontics needs to change, and that's just my personal opinion. I know I had to go on a little tangent there, but thank you.
No, Bailey, that was a brilliant.
We see these patients coming in. They have all different signs and symptoms, but what may not be an effect for one person may be life-altering for one, right? And so going back to what we were talking about earlier about the AHI being low and the RDI, we've had patients that have never been diagnosed with sleep apnea. They've tried CPAP. They've tried, proton pump inhibitors, and for that person, just 1/10 of a millimeter or 1 millimeter may change their entire life, right? And so something small that some people may downplay, and we see this all the time with our patients because a lot of complicated cases do come to our offices, right? We see that even just a little bit, whether it's adjusting their bite a little bit, changing their the height of their orthotic may change their gait, right? It may change the way they breathe. Those things may be small to one person, but may be huge to another. So what we realize is we don't discount what any of our patients say. If we must, as providers, actually listen to what our patients say and don't discount it, because they're living with themselves 24/7, 365. And they're coming to see us, for a consultation or an appointment. So we have to be extremely cognizant. And a lot of doctors, a lot of dentists, physicians will kind of write off patients. Oh, they're crazy, or oh, they're this or that. No, you can't do that. You actually have to listen to them, right? Because they're saying stuff that you have to pay attention, because there's certain signs and the way they're speaking, the emphasis can change their entire life, right?
And I think what you've just said is a perfect I guess it's a perfect concept to illustrate that while, of course, expansion is a revolutionary tool in orthodontics, which we will talk about in just a second, it is not the only tool. And there are so many ways that we can help a patient who, has some of these types of issues. And I think it's very important to recognize that, right? And very important to know that, perhaps things that we hold dear as, structural interventions that make sense and doing things like that. I mean, sometimes you don't need to do everything under the sun to get somebody better, right? And I think it's very important to see patient care through that lens, right? But, of course, on that front, of course, expansion remains one of the most sensible things that we can do to, when appropriate, augment somebody's jaw structure, right? Expansion is, relatively non-invasive. It is, it is a sensible thing to do when you have constriction of the arches. It is a sensible, direct thing you can do to improve tongue space. It is a sensible, direct thing we can do to improve nasal breathing, which will improve oxygenation. It is, and of course now, as opposed to 10, 15 years ago, we thankfully have a lot of tools at our disposal to do that for people of all ages. Of course, we've always been able to do it for young kids and so forth, but now we have, more degree of being able to execute that treatment. And it's something that people should really look at if they're looking to improve, certain quality of life, concerns that could be physical. And sometimes people don't know that they're physical, right? Like anxiety and depression, right? You don't know that perhaps this is a physical problem.
And I mean, I'll give you an example. I had a patient came in yesterday, asked her, how is your sleep? Has it improved? And she kind of mentioned that she didn't really feel like she had any sleep issues before her expander. So I was like, well, how is it now? She's like, I actually get more restful sleep. She didn't even know she had a possible problem until it was actually better now that she got an expansion. So we may not even know. I mean, a lot of things go undiagnosed, go unchecked or unrecognized, right? And so this patient has had a class 3 bite for all of her life. And now she's understood that, hey, fixing that with an expander has actually improved her sleep and her rest.
So
as well.
Does someone who wants expansion, do they have to just be in a class 3? Do they just have to
No,
be in a class 3?
you can be in any kind of bite under the sun, or an absolutely perfect bite. And just the whole concept, the whole complex could get wider, right? You could have an absolutely perfect bite that, again, is a constricted one. And that is not a very accommodating house for the tongue. That is not a very, not very conducive to the muscles of the face supporting the jaw in a therapeutic position, right? And you can get that by increasing height, you can get it by increasing width, and you can get it by increasing projection.
What do you say to orthodontists who don't necessarily have any sort of emphasis on the airway or focus on the airway? They're not doing any sort of scans. They're only doing just X-rays. They're not doing of the airway.
Well, that's actually.
They should get a new job.
Well, let me talk about that actually, because that's a subject somewhat sensitive to me because I'm a radiologist and a clinician. I don't think you actually have to have access to 3D technology to do good airway-focused orthodontics, right? I worked in a pediatric practice for the first, 3 years of my career. Maybe 4, actually, no, it was like 5. Yeah.
Half a decade.
So, where we didn't have access to CBCT, and I would, of course, refer out for it and order it when necessary, but, it's... imaging examinations are all about what information you can derive from the study that you've taken. I happen to think that I might be a bit better than the average dentist at getting a lot of information out of my panoramic image and my cephalometric image than someone else. But again, and that's only because I went to extra school for that, so I'm not trying to brag or nothing. But
Humble brag.
It's because I didn't know nothing that I went to school for. But anyway, but that it's about what you can use, right? There are a lot of people out there with CBCTs that are simply just reconstructing pan and ceph from that, and then it's kind of like you might as well just have 2D if you don't know how to scour the heck out of that data set. So So B, I think to answer your question, it's not a matter of who has what technology and who's doing what kind of scans. It's more so about understanding what you are reading, right? Of course, with a really good two-dimensional analysis, a panoramic and a cephalometric, right? You can see airway depth, you can see jaw, relationships and position relative to each other, relative to the skull base. You can see prominence of adenoids. You can see how thin those black air spaces are around your turbinates. You can see a lot of shit, right?
Well, I think that, hold on, I think that even more simply what I felt like you were talking about was your mindset is looking at things differently first and foremost.
Yeah.
Right?
Airway focus.
Like you're looking at
exactly.
now forget the 2D, 3D,
yeah,
whatever.
exactly.
Anything,
that
right?
doesn't actually matter.
Like you're first looking at, is that patient like physically, do they look recessed? Have you opened up their mouth?
Yeah.
Do they have extremely large tonsils?
And if they
Can you
are-
see the back of their freaking throat?
Yeah.
Right? Like you don't have to you don't even have to have any technology.
Exactly.
And the only solution isn't just jaw surgery.
Yeah. So I mean, I think that where you're talking about 2D, yes,
clinical examination.
in the modern dental office, but you could do this clinical examination
Yep.
anywhere in the world without
Correct.
electricity as well. Right?
Absolutely.
For the most part.
Absolutely.
Right? So
Like
it's just your perspective and how you're looking at this human being.
Yeah.
Right. And then looking actually inside their throat, their mouth, and then looking logically
Yep.
at their jaw positioning.
Correct.
Have them, like you said, breathe. If one nostril comes in more than the other, then probably there's some type of nasal issue going. Like it's common sense, honestly. Like the first thing we do is we breathe. Like that's
So why are you an advocate
This
for
is-
MSC? If these small kind of airway problems are kind of, let's say, minor, not as severe as someone with a completely recessed face.
But the MSC is a part of our toolbox that we didn't have 15 years ago, right? And so
But right now,
the orthodontist that's looking at this person, at this patient, are they breathing well? How is their airflow? And then how does that relate to their jaw positioning? Can we move it wider? Can we move it forward? There's other things that we can do.
and just to be clear, they don't have to be in an underbite or anything, so they can.
Absolutely.
Yeah.
You
Yeah.
say that.
Yeah.
You don't
I
have
mean,
to be an underbite.
Yeah, you can be in any kind of bite under the sun and have something that deserves attention for structural modification.
So-
But this has been actually a brilliant lesson number one in maximizing your yield in clinical radiographic correlation, right?
Right.
You need to get the most you can out of your clinical exam. You need to get the most you can out of your radiographic exam,
History.
whatever it is that you have, history and everything else, right? And we take, of course, questionnaires and inquiries that patients, will fill out or tell us about, or of course, subjectively tell us about their experience when we say, hey, what brings you in here today, and putting that all together is a huge part of our job, of course, as doctors.
I mean, I would say that between the two of us, we're pretty big picture thinkers, right? And we synthesize data very well, right?
I think you synthesize data very well.
I think you do.
I don't think I really do. I just.
But I'd say
just
even
collect
together
data.
as a tag team, I'd say one of the things that we are pretty good at is kind of coming up with a story about what our patients' lives are outside of here, and then figuring out what's the best solution for their life, right? Like we see patients that, for example, they can't wear Invisalign and they're not going to take their aligners in and out, right? So for that patient, we'd be like, oh, maybe braces may be better for them. Or, maybe a patient is going to not have good oral hygiene around their expander, right? That's problematic too. So maybe they need jaw surgery instead, right? So, I'd say one of our skill sets together as a team is actually look at the big picture and finding the right solution for each patient. Because it's never a one size fits all, right? If anybody tells you that,
Right.
don't believe it.
Yeah. So that being said, the standard of orthodontics is amazing, right?
What? Yeah, that's a curveball, man.
That's a good response.
Well, if you ask 9 out of 10 orthodontists, they're going to tell you, of course.
I mean, we see.
Prove
Look,
to
I'm
me
a.
why orthodontics,
Alright.
the standard of orthodontics is
All
better.
right, so I'm a general dentist that does a ton of ortho, right? That does MSC, etc., right? And so I guess I'm not as he's an clinically trained, classically trained orthodontist. So I can talk, I guess, shit about the orthodontic community. I see some shit orthodontics coming out. I see, 13-year-olds with their second molars being pulled. I see, these kids that are done with their orthodontics that still have class 2s coming out. I'll give you a real life example. Patient comes to me literally as soon as their braces came off for me to clean their teeth. I think like a 15-year-old male. And I'm cleaning, and I'm like, are you done with phase 1? And he's like, no, I'm done with my braces. And I'm like, you have like an overbite. He's like, no, I'm done. I'm waiting for my retainer. I'm gonna get them next week. And I didn't know what to say, because he's literally walking around with a class 2 malocclusion, and he just got his braces off. So I go to mom, and I'm like, Mom, like, I don't want to throw anybody under the bus, but like, did you bring this up? Because he still has an overbite. And I pointed it out. And I was upset for the parents and the child, but I just couldn't keep my mouth shut, because it's like, on my end, if I see something, I gotta say something. Even though they literally came from the other orthodontist office.
Right, like unnecessary extractions. That's insane.
Well, now this
This is a real life story, by the way. This is not BS. This is actually happened.
But this may be a good nugget for some healthy debate, right? And I think what you're saying, and perhaps for that particular case, like something alarmed you about what the orthodontist was able to let walk out their door with their signature on it, right? Now, there are situations, though, right, where, you may want to, right, in the interest of non-retractive orthodontics. Let's talk about this, right? Because, it seemed that your opinion of the patient being left in an overbite was criminal, right? I leave patients in overbites all the time when I don't want to retract the maxilla or the maxillary arch, because a lot of mandibular propulsive mechanics are known to work against the maxilla. So sometimes, the best that we can do to not trade or take away from the good jaw just to get the bad jaw in position is to at least try to set it up for the best environment you can. And of course, layer on other
for sure do not think that was the case. I think the case applies to you as an airway focused orthodontist that wouldn't do that. But I'd say a lot of the orthodontists terrible. I definitely wouldn't work on my dog. But I'm just letting.
I just wanted to make it clear to the audience that it's not the presence of an overbite or something after orthodontics that is somehow right. But yes, I think there must have been features about that case that really made you feel like, holy shit, like what? You know what I mean? But
considering I've done like hundreds and hundreds of cases of orthodontics, yes.
So would you say?
Well, but that's actually something that I sometimes have to talk to mom and dad about, right? Like if, hey, we're going to leave Jimmy in a little bit of an overbite and give kind of that little extra room to grow, because again, I don't believe that it's appropriate to roll those front teeth in and back just for the purpose of closing the overbite or making it look like.
I want to appreciate your conversation with the parent. That's not common. Let's call a spade, right? The orthodontic community, basically, a big portion of orthodontic offices are orthodontic mills that literally put on brackets, put on braces, push everything back. They close patients that have small teeth, that have diastems, they close them, and then what happens? The patient gets, right after the braces are off, they get the diastems again. Because that's not the right position of their teeth.
So why is it being done inside of the mouth?
Because it's profitable.
Because headgear is ugly, right?
No, because it's profitable, right? You can literally put on these braces, get the mom and dad happy, because mom and dad are looking for straight teeth for their senior portraits, right? They're looking for the straight teeth for the sweet 16s, right? They're not focusing at how their child, Susie or Billy or Johnny, is going to be when they're 65 or 45, right? And so these orthodontic mills, what they're doing is they're placing brackets, they're using the straight wire orthodontics and retracting stuff, right? Just to make mom and dad happy, right? So, think about it. The amount of patients that we have that don't know how to properly use their retainers, right? So they give Johnny their retainer when they're 16. and then they let them go. Well, the retainers break or the retainers shift. They're just there to make mom and dad happy, or they'll put a lingual retainer so because the parents got an insurance policy out of that lingual retainer because the teeth aren't going to shift.
Yeah.
Well, the back teeth are still shifting.
Yeah. What do you go ahead and say?
No, I think I was going to say this, that it's very important also in the context of this discussion to understand that, I think it's very clear that our opinion collectively is that, the orthodontic profession is behind when it comes to assigning a standard or even just a lens through which we look at the quality of our treatment, right? I think that's definitely true, right? The orthodontic profession certainly has not, in its orthodoxy, been able to really kind of clamp down on a lot of the topics that we hold near and dear to us. Okay, which we believe is obviously a better lens, right? Looking at somebody's overall health, airway, this, that, whatever, and perhaps doing things that are a bit off label, right? But it is very important to stress that what the orthodontic profession does have to offer is a basic mechanic, basic, I guess, fundamental understanding of the science of tooth movement and even orthopedic, sort of principles that are important for us to then apply differently, right? But without those basics, without those fundamentals, we also expose patients to liabilities of, perhaps people going too much in the other direction. Obviously, we don't have to even make this podcast about, instances where untrained people doing orthodontics is very troublesome. Include a bunch of links to whatever CBS News story you want for that. Okay, so you see what I'm saying, right? That it's important to respect and understand the mechanics and biology of tooth movement, for which the orthodontic profession has actually laid out some pretty good standards for those things, and it's just important, I think, to apply those properly.
Absolutely,
right?
I think where my problem lays with the standard of orthodontics is extraction and retraction.
So criminal, the cops are here.
Yeah, exactly. Well, yeah, at the risk of sounding inflammatory, I do think that it is somewhat, forgive my language, to ignore and accept the practice of really, kind of taking unnecessarily healthy body parts out of somebody's mouth just to fit our orthodoxies about how we think teeth and jaws should line up, right? And of course, we've seen so many people harmed by that practice. And it's not necessarily even the practice that, causes the harm a lot of the time, but it is actually just ignoring that there's perhaps a different way that we could have looked at the problem in the first place that would have then led to better decision making and understanding what tools there are, including no treatment. By the way, right? It's a feeling of being forced to have to say, okay, we're going to straighten your teeth, and this is the only way we can do how. Well, okay, what are the risks, doc? Okay, maybe 10 years later you'll get some, little disturbances in your jaw, and maybe 20 years later you'll gain 20 pounds, and then you're going to have, start developing sleep-related breathing issues, and then you're going to start precipitously grinding away your teeth because, your jaw is in a very constrained position. And now we're losing at perhaps a bit more accelerated or more than customary rate, occlusal support and this and that. And then that's going to lead to other, it'll act as a catalyst to having other jaw and neurological problems. Like, the fact that this isn't necessarily talked about, like, that's kind of why we're sitting in this seat today, right? To bring that awareness to the people. Yeah, well, I think the acceptance of extraction treatment is absolutely horrible, right? Now, of course, there are situations. If you are, a mom or dad watching this, podcast from home, I don't want you going out there and starting, legal action on your orthodontist. They're simply doing their best to, straighten the teeth and give, the kid a good bite the best way they know how. I had similar treatment myself when I was.
We both
we both did, right? You know, when I was a teenager, and by all measures, I'm kind of living okay, but I have problems that I know about.
We're doing FME on you in the next month.
Yeah.
So let's talk
But,
about.
hey, no, but I'm just saying, by orthodontic standards, I think my treatment was done well. But this is just
in
for
modern,
me to.
in orthodontic standards 30 years ago or 20 years ago.
Correct.
And it's even still now, and that's why we're doing what we're doing.
Yeah. Now, again, the purpose of this commentary is really to just, bring that awareness of a frame of mind that, hey, there do exist, or there does exist, I think, a subset of our profession where we are really trying to dedicate our practice to understanding these issues.
Yeah.
Okay. And when you begin to do that, then you begin to learn that there are if you can't do something the right way, then you just don't do it. Or there's often, though, something that you can do. And, and what you shouldn't do is go the other way.
Yeah.
Right.
Now, a question for you.
Which is what?
Which is the extraction and retraction and just pulling things back and doing constrictive retractive treatment versus expansive protractive types of treatment. Right.
Now, question for you is, we have patients that are older than us, right? We're at mid-30s to 40 almost. What if a patient has some of these UARS type of symptoms, that has had extractive orthodontics, that's in their mid-50s or 60s, that's having these symptoms? What do we do for them?
Well, I think we can, of course, contemplate, just like we were talking about, expansive protractive treatment.
What's the age limit for?
There is no age limit to do expansive protractive treatment. It just depends on, of course, what we need to do to make the treatment possible, to make it feasible, and then also what we have to consider the risks, and we have to consider the invasiveness of the procedures, because there are things that we can do.
So can we do MSC on, let's say, a 65-year-old male?
Yes, you can.
Is that not the most difficult demographic to achieve expansion?
Yeah, mature adult males is definitely the most difficult. And
How
these
successful
days,
is it?
well, I think these days we can quite predictably do it.
Why can we do it more predictably than before?
Yeah, well, I think I think with the advent of being able to have mechanically stronger, better performing appliances, like custom MARPs and FMEs, of course, that's one hurdle, to overcome, and digital planning and all that. That's another one. And then, of course, being able to do bone releasing cuts in the midline and in other areas. Perhaps there are some that are within the scope of what we do, and perhaps there are some that we refer out to get, perhaps a more robust set of cuts done to make expansion
Like
feasible.
the dome surgery and things like that.
There are things like that, and of course we can talk about the merits and pitfalls of, or what we believe are merits and pitfalls of those types of procedures, and the specificity of those in a different episode.
Hi, guys.
Yay!
All right, we're almost done with the podcast. Hi, Melina. Hi, guys. How's this?
Hey!
Wow. For the people.
Hey!
Yes, sir. Okay. Last thing is,
Yeah, jaw MSC over jaw surgery.
yes.
Yeah.
Why should you get
If you're an athlete, I mean, one, your recovery is significantly less time, less painful. Yeah, maybe the jaw surgery could be a little bit quicker, but you're gonna be out of commission for a while. If you're gonna get plates, those cuts have to heal. We've had patients where, sadly, they haven't healed in like 4 or 5 months, and their teeth are still, and their jaw is still moving. So sometimes some sports like MMA, mixed martial arts, that's a problem to have plates and things like that. So definitely, I mean, you have to see the pros and cons of both MSC versus jaw surgery. But I think that MSC overall, as a whole, by and large, is more conservative and less invasive.
because it's filling bone and not putting plates.
Yeah, you're basically expanding bone and then it's filling itself in. You're not making significant cuts. I think it's a little bit more conservative.
Mm. Yeah, I think so. I mean, I think it's very important, of course, to understand this problem from the perspective that obviously, we want to treat where the anatomic deficiency is, and it's, not always in the transverse dimension. But by improving the transverse dimension via expansion or what have you, of course, that is a window of opportunity into solving orthodontic problems otherwise not possible, right? Otherwise thought to be only as surgery can fix this kind of case. So we're seeing a lot less cases be, oh my gosh, this is a slam dunk surgery case, right? There is also a sequential progression to the thought process in the treatment planning where it's like, let's do a lesser intervention as a means of setting up your teeth anyways, right? Orthodontist's job in a surgical case is to straighten the teeth, but straighten your teeth on a little wider platform and do some benefit to the nose and the tongue space, and then see where we land, right? If we need, for therapeutic benefit purposes, to actually move the jaws forward and rotate them or whatever have you, we will do it, right? And we will, I think, reevaluate for jaw surgery 6 to 12 months into the case or whatever, right? It's a common workflow for someone like myself who sees a problem that we could perhaps improve, even if not thought to be potentially curative. Of course, in an exceptional situation, it can be. And so it kind of then remains in the court of the patient to see what they value, right? Do they value conservativity and being able to make that choice for themselves, or do they value maybe a little bit more of a swift outcome and be done, and keeping the orthodontics relatively simple, right? We can do complex orthodontics and do a lot of things.
So basically, it's like staging it.
Yeah.
You can expand,
Correct.
get it ready for surgery, and if the patient chooses to do surgery or not, that's up to them. But they're still getting some type of benefit, right? And then surgery may be increasing the amount of benefit, but if they don't want that invasiveness or the recovery or cost as a factor,
doesn't mean we can't help them.
Doesn't mean they can't help them. So you don't need to go 0 to 100 real quick. You can stage it out, and MSC is a very good part of that.
Tool to yeah.
Not as invasive as jaw surgery, and it's not surgical, right?
Not totally non-invasive, but a lot less invasive, right?
I mean, it's an inpatient, outpatient procedure. We, it's for us. We do this pretty often now. It's relatively straightforward. A little discomfort for a couple of days max. If we make a split on some of our male patients, some of our older patients, that's a little bit uncomfortable, but usually within a couple of days, I would say it's probably less painful than an extraction, in all honesty.
Right, I agree.
And so, you've had a MSC, and I think most of our patients within a few days, even a day or two, are back to normal, and they're actually kind of surprised. Yeah. They're pretty shocked because psychologically, MSC is like, split and all this stuff, but they're like, whoa, it wasn't as bad as I thought it was. It isn't as bad as it sounds. An extraction, in all honesty, is worse.
I was in more pain when I got my wisdom teeth taken out than I was when I got MSC installed.
Yeah.
I was like, granted, I was excited, but it wasn't as much as the pain from getting the wisdom teeth taken out.
Be on the lookout. Definitely follow our Instagram channels, the Jaw Complex, Team Dental, our YouTube channel.
Yeah, buddy.
Yeah, buddy.
Yeah, buddy.